Today we will make obstructive and restrictive lung disease very easy. The key idea is this. Obstructive means you cannot get air out. Restrictive means you cannot get air in. Now we will build this step by step using spirometry first, then severity grading, then gas transfer tests. First, obstructive lung disease. Obstructive lung disease means reduced airflow, mainly during expiration, because airway resistance is increased and air gets trapped. There are two main mechanisms that cause obstruction. Mechanism 1 is increased airway resistance. This happens from bronchoconstriction, like asthma. It also happens from inflammation and mucus, like chronic bronchitis. Mechanism 2 is loss of elastic recoil and airway collapse. This is the emphysema mechanism. Here the lung parenchyma is destroyed, radial traction is lost, and small airways collapse dynamically during expiration. The result of obstruction is air trapping and hyperinflation. Residual volume increases, and total lung capacity also increases. Common causes of obstructive lung disease are asthma, chronic obstructive pulmonary disease, meaning chronic bronchitis and emphysema, bronchiectasis, cystic fibrosis, and alpha-1 antitrypsin deficiency. Now, restrictive lung disease. Restrictive lung disease means reduced lung volume and reduced compliance, so the lungs cannot expand properly. All lung volumes fall proportionally. The main pathophysiology is reduced compliance, meaning a stiff lung, and this happens in two broad groups. Group 1 is intrinsic, also called parenchymal causes. Here, inflammation or scarring affects the lung tissue itself, as in interstitial lung disease. This increases stiffness and increases elastic recoil. Group 2 is extrinsic, also called extraparenchymal causes. Here the lung tissue may be normal, but expansion is limited by the chest wall, pleura, or neuromuscular system. The result is a proportional reduction in all lung volumes, including total lung capacity, forced vital capacity, and forced expiratory volume in 1 second. Now the causes of restrictive lung disease. Intrinsic or parenchymal causes include idiopathic pulmonary fibrosis, sarcoidosis, pneumoconiosis such as asbestosis and silicosis, hypersensitivity pneumonitis, also called extrinsic allergic alveolitis, drug-induced lung disease such as amiodarone, methotrexate, and bleomycin. Extrinsic or extraparenchymal causes include chest wall problems such as kyphoscoliosis, ankylosing spondylitis, and obesity. Neuromuscular causes such as myasthenia gravis, Guillain-Barré syndrome, and motor neuron disease. Pleural causes such as pleural effusion, pleural thickening, and pneumothorax. Now we go to diagnosis, and spirometry is the cornerstone. The key differentiator is the ratio, FEV1 over FVC. In obstructive disease, the ratio is reduced, less than 0.7. In restrictive disease, the ratio is normal or increased, meaning 0.7 or higher. Now look at FEV1 and FVC. In obstructive disease, FEV1 is significantly reduced, usually less than 80% predicted. FVC can be normal or reduced. In restrictive disease, FVC is significantly reduced, less than 80% predicted. FEV1 is also reduced, but proportionally, so the ratio stays normal or high. Now the mixed pattern, which is high yield for MRCP. Mixed obstructive and restrictive disease is diagnosed when FEV1 over FVC is less than 0.7 and FVC is less than 80% predicted. That pattern means there is both an obstructive and a restrictive process. For example, a smoker with chronic obstructive pulmonary disease who also has pulmonary fibrosis. Next, severity grading. For obstructive disease, severity is graded using FEV 1% predicted, using gold-style cutoffs. Mild obstruction is FEV 180% or more. Moderate is 50% to less than 80%. Severe is 30% to less than 50%. Very severe is less than 30%. For restrictive disease, severity is graded using FVC percent predicted. Mild restriction is FVC 70 to 80%. Moderate is 50 to 69%. Severe is less than 50%. Now we move to gas transfer, DLCO, also called TLCO. DLCO measures the integrity of the alveolar capillary membrane. Start with normal DLCO. In obstructive disease, DLCO is usually normal in chronic bronchitis. In asthma, DLCO can be normal or even high. In restrictive disease, a normal DLCO points towards extrapulmonary restriction. Think chest wall deformity, neuromuscular weakness, or obesity. Now reduced DLCO. In obstructive disease, a reduced DLCO strongly suggests emphysema because the alveolar capillary membrane is destroyed. DLCO can also be reduced in severe bronchiectasis and cystic fibrosis. In restrictive disease, a reduced DLCO suggests intrinsic parenchymal disease. Think idiopathic pulmonary fibrosis, sarcoidosis, and asbestosis. Now increased DLCO. In obstructive disease, asthma can produce increased DLCO because of increased pulmonary blood flow. In restrictive disease, DLCO can be increased in pulmonary hemorrhage, such as Goodpasture syndrome or Wegener's. It can also be increased in left-to-right cardiac shunts and in polycythemia. Now we add one more test that makes MRCP questions much easier: the transfer coefficient, KCO. KCO equals DLCO divided by alveolar volume, VA. It tells you the efficiency of gas transfer at the alveolar level. If KCO is reduced, this points to intrinsic parenchymal lung disease, such as idiopathic pulmonary fibrosis. If KCO is normal or high, this points to extrapulmonary restrictive disease, such as kyphoscoliosis or neuromuscular weakness, because the lung tissue itself is relatively preserved. So here is the high-yield combination. If spirometry shows restriction, meaning low FVC, with a normal or high FEV1 over FVC ratio, and KCO is normal, that strongly suggests an extrapulmonary cause of restriction. Finally, a quick MRCP summary to lock it in. Obstructive equals low ratio, less than 0.7, and air trapping with increased residual volume and increased total lung capacity. Restrictive equals low volumes, especially low FVC and low total lung capacity, with a normal or high ratio. Reduced DLCO in obstruction points to emphysema. Normal DLCO in restriction points to extrapulmonary restriction. Reduced KCO points to intrinsic parenchymal restriction. That is the full framework to answer almost any MRCP question on obstructive versus restrictive lung disease.